Hey everyone, welcome back to the channel. If you're studying pharmacology, you are going to love today's topic because we are diving deep into one of the most classic, high-yield antibiotic classes out there, the tetracyclines. Now, I know antibiotics can feel like an endless list of names to memorize, but stick with me. By the end of this video, I promise the tetracyclines are going to click and you'll walk away with the mechanism, the pharmacokinetics, the clinical uses, and honestly the mnemonics that examiners absolutely love to test. Quick roadmap: they hit the 30S ribosome, they're bacteriostatic, and every drug in the family ends in cycline. Keep those three anchors in your head. Hit that like button if this helps, and let's get into it. Okay, before we get into any of the science, I want to make you a promise. By the end of this video, 3 tiny mnemonics are going to make the tetracyclines almost impossible to forget, and I'm putting them right here at the start so you know exactly where we're headed. Here's the hook. Mnemonic 1. Tetra locks down safe usage, teratogenic, empty stomach. Take upright, risk of photosensitivity. Avoid under 8. Mnemonic 2. Really cute microbugs. Nails the atypical coverage, Rickettsia, chlamydia, mycoplasma, borrelia. And mnemonic 3, MAID, tells you what wrecks absorption: milk and dairy, antacids, iron and calcium, and divalent cations. Don't worry if none of that makes sense yet. That's the whole point of the next few minutes. Keep these 3 little words in the back of your mind, because everything we cover, the mechanism, the pharmacokinetics, the clinical uses, is going to feed straight back into them. Stick with me and let's build up to it together. So let's start with the big picture. What actually are the tetracyclines? These are broad spectrum, mostly bacteriostatic antibiotics that were discovered way back in the late 1940s as natural products of Streptomyces bacteria. The very first one was chlortetracycline. Here's why they matter to you clinically. They inhibit bacterial protein synthesis by binding the 30S ribosomal subunit, and they cover a huge range of bugs. Gram-positives, gram-negatives, and crucially the atypical and intracellular organisms. Think Rickettsia, chlamydia, mycoplasma, and borrelia, the ones that beta-lactams just can't touch. And if you remember one drug from this whole video, make it doxycycline. It's the workhorse of the class. Fantastic oral absorption, a long half-life, and it isn't cleared by the kidneys. We'll keep coming back to doxycycline, so keep it on your radar. Alright, let's organize the family, because tetracyclines get classified by their half-life and how well they're absorbed orally. Don't just memorize this blindly, understand it, because it explains the dosing. The short-acting group is your oldest agents: tetracycline, oxytetracycline, and chlortetracycline. These are the ones with poorer oral absorption. The intermediate group includes dimeclocycline and methacycline. Then the long-acting group, and this is the important one for the wards: doxycycline and minocycline. Reliable absorption, long half-lives, once or twice daily dosing. And finally, the third generation, the glycylcyclines and their cousins, tigecycline, eravacycline, omadacycline, and tetracycline. These were engineered specifically to get around resistance, and we'll dedicate a whole slide to them later. For now, just slot each drug into its group. Let's talk chemistry for a second, and I promise to keep this painless because it actually explains a lot of the pharmacology. The name gives it away. Tetra means 4. These molecules are built on 4 linearly fused 6-membered rings labeled A through D, a hydronaphthacene skeleton. Hanging off those rings you've got a bunch of hydroxyl groups, carbonyls, and a dimethylamino group, and the exact position of those side chains is what makes doxycycline behave differently from old school tetracycline. That's your potency, your stability, your absorption. 2 practical things to lock in. First, they're amphoteric and poorly soluble, so they're dispensed as hydrochloride salts. And second, this is the big one, they chelate divalent and polyvalent metal cations, calcium, magnesium, aluminium, iron. Remember that because it's the entire basis of their food and drug interactions, which we'll hit soon. Okay, mechanism of action. This is the heart of the whole video. So let's walk through it step by step like a little story inside the bacteria. Step 1, the drug has to get in. It enters partly by passive diffusion through porins and partly by an energy-dependent active transport system, and it concentrates inside the cell. Step 2, once inside, it binds reversibly to the 30S ribosomal subunit, right at the acceptor site, the A site. Step 3, and this is the money step, by sitting in the A site it blocks aminosyl tRNA from attaching. No amino acid can be delivered, so the peptide chain simply can't grow. Step 4, protein synthesis grinds to a halt, and because the binding is reversible, the effect is bacteriostatic. We stop them multiplying rather than blowing them up. And here's the elegant part, selective toxicity. Our human cells don't have that active transport system, so our ribosomes are largely spared. That's why the drug hurts the bug and not you. Now pharmacokinetics, because this is where tetracyclines get really testable. Let's go absorption, distribution, and elimination. Absorption, old tetracycline, is only about 60 to 80% absorbed, but doxycycline and minocycline are 90% or higher. The catch, food, and those metal cations knock absorption right down. So the counseling point is take it with water on an empty stomach and keep it away from dairy, antacids, iron, and calcium. Distribution, they spread widely into tissues and fluids. They concentrate in bile, but CSF levels are unreliable. Fun detail, minocycline actually gets into tears and saliva. Half-lives are long for doxy and mino, around 12 to 24 hours. And they're about 90% protein bound. Elimination is the clincher. Tetracycline and minocycline are cleared renally, but doxycycline, eravacycline, and omadacycline go out through the gut. That's your pearl. Doxycycline is safe in renal impairment precisely because it isn't relying on the kidneys. Let's talk spectrum, and honestly this is where tetracyclines flex, because broad spectrum is not an exaggeration here. On the gram-positive side, you've got streptococci, Staph aureus, including some community-acquired MRSA and the Epstein-Barr Cutibacterium. On the gram-negative side, Haemophilus brucella, Vibrio cholerae, Yersinia pestis, that's plague, and Bartonella. But the real star of the show is the atypical and intracellular column, and this is what examiners love. Rickettsia, so Rocky Mountain spotted fever, and typhus, chlamydia. Mycoplasma pneumoniae. Borrelia, the Lyme disease organism, and they even hit Plasmodium for malaria prophylaxis. So when a question describes an atypical pneumonia, a tick-borne illness, or an intracellular organism, your brain should immediately flag tetracyclines, usually doxycycline. So where do we actually reach for these drugs in real life? Let's run the clinical uses, and you'll notice doxycycline keeps showing up. Acne vulgaris, that's doxy-mino, and the newer tetracycline. Rickettsial infections like Rocky Mountain spotted fever. Early Lyme disease, atypical pneumonia from Mycoplasma or Chlamydophila, and Q fever. Then the sexual health side, chlamydia and pelvic inflammatory disease, and increasingly doxy-PEP, doxycycline post-exposure prophylaxis, which the CDC put out guidance on in 2024. Add malaria prophylaxis for travelers, the zoonoses, brucellosis, cholera, plague, tularemia, and doxycycline even shows up in H. pylori quadruple therapy. The takeaway, tetracyclines are the answer for a surprisingly wide swath of infections, especially the weird intracellular ones, so keep this list handy. Of course, no antibiotic story is complete without resistance, and bacteria have several tricks for dodging tetracyclines. There are 4 main mechanisms. Number 1, and the most common, efflux pumps. Proteins like theta and mepi literally pump the drug back out of the cell before it can work. Number 2, ribosomal protection proteins, TET-M and TETO, which physically knock the drug off the 30S subunit so translation can resume. Number 3, enzymatic inactivation, where enzymes like TEX chemically modify and destroy the drug. And number 4, reduced uptake through loss of porins or mutations in the 30S target itself. Here's the hopeful note, and it sets up the next slide. The third generation agents like tigecycline and eravacycline were specifically designed to slip past the efflux pumps, and the ribosomal protection proteins, which restores their activity against a lot of resistant bugs. Now the part your patients will feel, adverse effects. Tetracyclines are generally well tolerated, but there's a signature list of toxicities you absolutely need to know. Start with the gut, nausea, vomiting, and esophagitis, which is why we tell patients to take it upright with a full glass of water. Then photosensitivity, an exaggerated sunburn, so sun protection matters. The classic one, deposition in teeth and bone, causing tooth discoloration, and enamel hypoplasia in kids and the fetus, plus inhibition of bone growth in young children. A few more to bank. Rare but serious hepatotoxicity, especially high dose or in pregnancy. Vestibular toxicity, dizziness and vertigo, that's specifically minocycline. Superinfections like C. diff colitis and candidiasis, benign intracranial hypertension, or pseudotumor cerebri. And a niche classic, Fanconi syndrome from taking expired, degraded tetracycline. Okay, let's make the safety stuff stick with a mnemonic examiners genuinely love. Spell out T-E-T-R-A, tetra. T is teratogenic, avoid in pregnancy because it harms fetal bone and teeth. E is empty stomach. Take it with water and away from dairy, antacids, and iron. The second T, take upright. Stay vertical for at least 30 minutes to prevent that esophagitis. R is risk of photosensitivity, so sunscreen and sun avoidance. And A, avoid in children under 8 because of the tooth staining and slowed bone growth. Tie that to your hard contraindications: pregnancy and breastfeeding, children under 8, severe liver impairment, and be cautious in renal failure, with doxycycline being the exception since it's cleared through the gut. Nile tetra and you've basically nailed the safety questions. Let's zoom in on drug interactions, and here's the beautiful part. There's one recurring theme that ties almost all of them together: chelation. Because these molecules grab onto polyvalent cations, calcium, magnesium, aluminum, iron, zinc, anything containing those will bind the drug in the gut and tank its absorption. So dairy, antacids, and iron or calcium supplements are the usual culprits, and the fix is simple: separate the doses by about 2 hours. Beyond chelation, a few more. Tetracyclines can enhance the effect of warfarin, so monitor the INR-DO. Enzyme inducers like phenytoin, carbamazepine, and barbiturates shorten doxycycline's half-life. Combining with oral retinoids like isotretinoin stacks the risk of intracranial hypertension, so avoid that combo. And because they're bacteriostatic, they can blunt the bactericidal action of penicillins. Now let's give the new kids on the block their moment. The third generation tetracyclines, engineered specifically to defeat resistance. First, tigecycline, the original glycylcycline derived from minocycline. It's 4 only, and it covers MRSA, VRE, and a lot of multi-drug resistant gram-negatives. We use it for complicated skin infections, intra-abdominal infections, and pneumonia. Next, eravacycline, a fully synthetic fluorocycline, also IV, and it's potent against nasty resistant bugs like carbapenem-resistant enterobacterials and acinetobacter, mainly for complicated intra-abdominal infections. And omadacycline, an aminomycin that comes in both 4 and oral forms, great for community-acquired pneumonia and skin infections, and it overcomes both efflux and ribosomal protection. One bonus fact worth mentioning: researchers are even exploring non-antibiotic uses of these agents, immunomodulatory and anti-tumor effects. Cool stuff and potentially high-yield trivia. Before we wrap, let's stack up the mnemonics, because this is what's going to save you in the exam room. I've got 3 for you. First, tetra for safe use: teratogenic, empty stomach, take upright. Risk of photosensitivity, avoid under 8. We just covered that one, so it should feel familiar. Second, for that atypical coverage, really cute microbugs: Rickettsia chlamydia, Mycoplasma borrelia. That instantly reminds you tetracyclines are the go-to for the intracellular and the typical organisms. And third, for what blocks absorption, think MAID, milk and dairy, antacids, iron and calcium, and divalent cations in general. Keep those away from the dose. Drill these 3 and you've locked down the highest yield points of the entire topic. Alright, let's bring it home with the 5 key takeaways, the stuff I want burned into your memory. 1. Tetracyclines are broad-spectrum, bacteriostatic 30S ribosome inhibitors that cover the atypicals beta-lactams miss. 2-doxycycline is the workhorse, long-acting, well-absorbed, and safe in renal impairment. 3. Counsel on absorption. Cations, dairy, antacids, and iron chelate the drug, so separate the doses and take with water. 4. Respect the contraindications. Avoid in pregnancy and in kids under 8, and watch for photosensitivity and esophagitis. And 5. Resistance comes mainly from efflux and ribosomal protection. And the third generation agents, tigecycline, eravacycline, omadacycline, restore activity. And that's the tetracyclines start to finish. If this made the topic click, smash that like button, subscribe for more pharmacology deep dives, and drop any questions in the comments. I read them all. Thanks so much for watching, and I'll see you in the next one.